There she is.
All right.
There you are.
I've been talking to myself.
Okay,
It's
I
a
love
very
it.
quiet audience.
Move back to Peter. That's
All right.
where, yeah, that's where we lost you.
Okay.
Oh, okay. Yeah, so maybe
Can you see
we're
my
right.
screen?
I sure can. Yeah, I think we need to switch over to presenter view, but we're good. But it was the scene. I think it was like right after mist.
Okay. And
Yeah.
then if I do this, how about that?
Yes, absolutely. Got
Do you
that.
see yourself or just my
Just your screen. Yeah.
okay.
For some reason, yeah, you should be perfect. Perfect. Yeah.
Do you see the
This is
presentation?
yeah, this is the one. The
Okay,
Hobart.
all good?
Yeah.
All right. Again,
Okay.
we're new to
Go.
this world, right? Anyway, getting back, this is called the Hobart method from Peter Dargaville in Hobart, Australia. It's very similar to Lisa in that you still need a laryngoscope, but instead of using a feeding tube, you can use a vascular catheter. And again, the baby remains spontaneously breathing and no PPV is needed unless you so choose for rescue breaths. This is a video that I'm actually going to skip because I think that was the reason we bumped out last time. Moving on to aerosol. So this is the holy grail. We have been working on this for almost 30 years now. It'll be absolutely non-invasive, and that would be wonderful, but it's been very limited by technical problems. Finding the right size goes deep into the lungs, needs to be inhaled but not exhaled, delivered at a reasonable dose over a reasonable time. And we finally have a publication or a study that was positive. The Aero 2 trial enrolled over 450 babies, kind of the 23 to 41 weeks with the median 33. And they found that there was a 50% decrease in the need for reintubation and surfactant and reduced intubation and surfactant administration. This was published in 2020, but again, this is not clinically available yet as the device is not FDA approved. This is a video of the Aero 2 trial. As you can see, the interface is brilliant. It's a binky, so the baby still remains on CPAP and keeps the PEEP in his lungs and has the comfort of sucking on a binky. And then we also have the completion of the AeroFact trial, which was completed, but we're anxiously awaiting the results. And then there's on the table the NEO Inspire trial, which is CPAP alone versus CPAP with AeroFact. They're going to enroll 220 babies with the primary outcome for need for intratracheal surfactant in the first 3 days of life. They'll enroll at 3 centers in South Africa, birth weight 900 to almost 2 kilos, 27 to 34 weeks, and the babies will be on 25 to 35% oxygen. So we're anxiously awaiting that trial also. Now moving on to salsa. So chips and salsa, or it could be the dance salsa, but this has been around for over 20 years now, first published in the early 20s with case report or prospective trial. And the beauty of this is that it does not require a laryngoscope. So all you need to do is advance that LMA with your thumb and index finger until it doesn't go any further. And then the baby remains spontaneously breathing on CPAP. And you can use PPV if you want, if you so desire, but you do not need PPV on a routine basis as long as you have a device that can deliver continuous CPAP. So this video, we're hoping won't kick me out. There is like sound to it, but I'll just talk over it. So the baby still has the CPAP in place, but they're not going to be getting any CPAP through their nose. All of the PEEP is going to be obtained through the LMA with the T-piece. So this way we're able to maintain continuous CPAP. You can see that there's color change. The baby is spontaneously breathing. I'm going to give a couple breaths just to make sure we hear lung sounds. And then the surfactant is administered like it's advanced through a MAC catheter, but we'll talk at the end about all the different options. You don't have to use a MAC catheter, it's just what we'd use. So it's advanced to the red line, so that's puts the kind of the end of the MAC catheter, kind of in the mid-range of the LMA. We give 2 ml aliquots. The baby often desats a little bit as the surfactant fills their lungs. And then people say, like, how often do you know when to give the next aliquot? And we really just look for the baby sats to return. And that's how we know we should give it again. But being a little patient is helpful. This video looks like he's apneic, but he actually was breathing. And the beauty of leaving the CPAP in place is that it really doesn't interfere with it. And then when he has that LMA removed, his EEP is there right from his nasal interface. We put a OG back down and aspirate to see if there's anything in the stomach. He's still grunting, which I wish that wasn't the case for this video, but he did end up doing well. All right, so thinking about SALSA and the considerations is kind of a laundry list that we'll just march through. Efficacy, if it's easy and fast, it's only important if it actually works. So that the trials looking at Insure versus LISA have shown LISA to be superior. And the LMA versus Insure or LMA versus CPAP alone have shown LMA to be superior. And there's no published studies yet comparing the LMA to LISA, but there is one that's actively enrolling. It's called the Surf's Up trial. This is actually me surfing in Carmel last year, so I made it really, really small. And the Surf's Up trial is enrolled about a fifth of their enrolled population. And so we're anxiously awaiting that, and that will be a very, very large, very definitive study. Premedication. So my interest prior to using the LMA was using premedication for non-emergent intubations. So it's something that's very important to me. And the triple combination of an anticholinergic, an analgesic, and a muscle relaxant has been shown to decrease the time, number of attempts, and make the babies more physiologically stable. So it's recommended by the International Evidence-Based Group for Neonatal Pain, as well as the AAP and the Canadian Pediatric Society. However, if we're looking at using premedication for any of the other options, it leads to difficulties with rapid extubation. We saw some hypotension and delayed extubation with the morphine used in one of the trials. And also, you really need that baby to be spontaneously breathing. So use of a paralytic would be contraindicated. However, the beauty of SALSA is that it does not require a laryngoscope or direct visualization of the vocal cords. In my trial, we looked at the babies that, for the SALSA, we used just atropine and sucrose, versus the babies in the control arm, which were just on CPAP, or the babies in the LMA surfactant arm, which got the LMA surfactant. Both had the same intubation criteria. And so if a baby in either group met that criteria, they were intubated and given atropine, fentanyl, and rocuronium. We videoed and gathered the pulse ox data on these babies, and it was really important to me to make sure that the babies that were receiving the SALSA were not really stressed out by it. We found that the babies that were in the LMA group and ET tube groups had very similar heart rates. We expected that because both groups received atropine. But the SAT difference was statistically the same for both groups, despite the fact that they were very, very different in terms of pre-medication, with one receiving an analgesic and a muscle relaxant versus LMA just sucrose. Patient population. So insurance and thin catheter can be any gestation because you just need a laryngoscope and a skilled provider. But with SALSA in the past, the LMAs did not fit for less than 28 weeks and less than about 1,200 grams. 1,200 was kind of our lowest, although there was a few case reports of down to 800 grams with the currently available ones. But finally, I am thrilled to say that we finally have some on the market that are available for the smaller population. So the AirQ is the one in the middle that was FDA approved for less than 2 kilos. And hot off the press is the AirVia. The size small is actually FDA approved as of early March for less than 1 kilo. But thinking about that now, even that we have smaller LMAs for the smaller babies, the ones that were currently available still would have fit in babies that represent about 2/3 of the population. Thinking about FRC. So again, as you saw in that video, with the adapter and the T-piece, we're able to maintain PEEP delivery during the entire procedure. The other procedures like LISA and NIS also, because the baby is on a CPAP. However, their mouth is open during that time that the laryngoscope is in their mouth. We know that PEEP is important because it maintains the FRC and improves surfactant distribution. This is a video that I absolutely love because it shows the importance of PEEP. So this is a rabbit lung. I'm just going to speed it up, and they increase the PEEP to 15, and the baby or the rabbit has fully expanded lungs. And then the minute that they take the PEEP away, within 1 or 2 breaths, that EEP is just completely lost, all that recruitment. Just like that, you lose your PEEP. So moving on to positive pressure ventilation. Do you think positive pressure is good or bad? So in the past, it's been shown to be beneficial, recruitment of alveoli and increase your FRC. But recent data has also shown that even a couple breaths are associated with baro and volume trauma and excite the inflammatory cascade. So the beauty of SALSA is that you can use positive pressure. It's right there. If you need it for rescue breaths, or if you're someone who believes that you would like to use a little bit for recruitment, it's available, but again, you do not need to. The animal studies are conflicting of whether it's beneficial or not for the distribution of surfactant, but in clinical trials, LISA, which I mentioned before, has no ability to hook up that positive pressure bag to the surfactant feeding tube where the surfactant goes, versus Ensure that's done with positive pressure have shown that LISA is superior. However, in those studies, about 50% of the babies did receive positive pressure ventilation through a face mask. What about the potential adverse effects? So when I was developing this, something that was really near and dear to my heart was a potential risk of laryngospasm. So the first things is just kind of the beauty of not having to do a laryngoscope avoids the potential trauma and bleeding from that, vocal cord and subglottic injury. But as I got ahead of myself there, what about laryngospasm? It's a theoretic risk, but has not been reported in animal or human studies. Again, this has been occurring for about 20 years, and we have not had any animal or human reports of laryngospasm, but it is a theoretic risk. So I do recommend that intubation supplies and a muscle relaxant are readily available. At our facility, we have a little sheet on the back of our algorithm that shows what those doses would be, but they are not drawn up or out of the Pyxis. And again, it's theoretic. I've talked to many people about this, and the thought is that the babies their vocal cords are very adept at having liquid on them. For example, when they kind of have the up and overs, but they usually don't have laryngospasm. They usually just go apneic. What about provider skill and familiarity? So the other methods require somebody skilled in laryngoscopy and able to place a catheter or a feeding tube through the vocal cords. Whereas the LMA placement, just all you have to do is shove it down there till it doesn't go any further. So this is something that intubation is going by the wayside, and the skills are getting, and opportunities to practice are fewer and far between. As you all know, that they changed in the NRP guidelines for no longer routinely suctioning meconium stained fluid, and also the increased use of non-invasive ventilation. People are getting much more familiar with the LMA. As early as 20 years ago, it was just mentioned for the first time as an alternative airway device, even though it's been around for adults for decades. And then as recently as the 7th edition was the first time that it was incorporated the training into the NRP curriculum. And so now people are actually having some hands-on experience and required to place one during their NRP certification. And the newest version actually recommends or says that it can be considered as a primary interface to administer PPV in babies greater than 34 weeks. So in the past 20 years, it's gone from something where the LMA was somewhere on the unit what you're supposed to find and place, even though you've never done one before, if you can't intubate a baby, to something that you use if you can't ventilate, to now is a question of even using it as a primary interface. Again, the NRP, the newest edition, has actually even moved it from the there's two sections, either the basic or the advanced. And so LMA placement is actually in the basic. So all providers are learning that. However, despite the increased exposure and familiarity, most clinicians have had little or no experience placing an LMA. And what I commonly hear is, it looks easy, but I'm scared. And so what I also routinely hear is, after they've tried it once, is, wow, that was easy. So my recommendation or my request is that you just try it once and see what you think. In my study, we had a bunch of champions, actually a few champions, that were very familiar and very skilled at intubation, but were not familiar with an LMA. So we did just-in-time training where they practiced on a mannequin. And most were successful in a single attempt, and the procedures were completed within 35 seconds. And really important to me was how quickly they became comfortable. And so the learning curve with intubation, the anesthesia literature actually says you're not competent till about 40 to 60 intubations, whereas most providers were competent on their first and felt comfortable after even their second experience. So again, while there's still a learning curve, it's much less steep than intubation. So does it always go well? Most of the time. And so again, it's very easy, very quick, and most of the time it works great, but you have to keep expectations real. It's still a procedure. So there are times when you may say, that didn't go as well as it could have. That could have gone better. Sometimes, not very often, there is leakage around the mask to the point where you waste a dose or the baby did not respond because not enough went into the lungs. And also just keep in mind that RDS is RDS and surfactant is surfactant. So this is not going to be superior in terms of efficacy as compared to ET tube delivery, but it should be equal in efficacy and just easier. And so while most respond and wean their FiO2 rapidly, some may still need more than one dose or not respond as much as you'd hope. So again, just keep your expectations real. What we find is that if the baby weans rapidly down to room air and then over the next several hours, they kind of creep back up a little bit, I do not call that a treatment failure. That to me, that means that the baby got the surfactant into their lungs, they responded, and their RDS still requires a little bit of surfactant. So moving on to the published data, there's 3 animal trials and 8 controlled randomized trials that are published. When I first started thinking about this, wanted to make sure that it was at least equally efficacious. So we looked at the animal trial. Just going to breeze through this, but it just shows that on the bottom, the PaO2 was the controls that were just CPAP, and the top two bars are the PaO2s of the LMA and the intubation group, and they were equally effective in surfactant efficacy. And this was a group of women who were very, very skilled at piglet intubation, but had never placed an LMA, and they were 6 times faster and required 2 times fewer attempts with the LMA. Equally effective with and without positive pressure in rabbits, and animal trial showing that there's good distribution and good PO2s. This is a laundry list of the randomized controlled trials. Again, kind of a laundry list of if they're compared to Ensure or CPAP alone, difference in weights, but all are greater than 1.2, except for the most recent, which was enrolled down to 800. And that again was with the previously available LMAs. And kind of whether or not they used pre-medication varied. And the findings are a lot to read, but just kind of in summary, they all favored placement of the LMA. In the meta-analysis, the post-surfactant FiO2 requirement, the kind of the blue one that says CPAP, is comparing the LMA versus CPAP alone, and the ET tube is Ensure. And as you can see, the CPAP versus LMA surfactant was statistically improved or significant for post-surfactant FiO2 requirement, and LMA versus Ensure was equally effective, which is what we wanted to see because we want it to be equally effective to the gold standard. And then intubation and mechanical ventilation was decreased for both. Kind of breathing through my trial, we enrolled 103 babies. Now it's been over 10 years, which is crazy. And I really wanted the babies that were kind of middle of the road. So the ones that are going to get better on just CPAP alone, we don't want to do an unnecessary procedure. And so wanted to get the babies that were kind of in the 30 to 40%, which were in the gray zone of whether or not you could just help them over that hump and try and avoid intubation. Again, they differed only in whether or not surfactant was administered. They were right in kind of the 2 kilo kids, right about 32 weeks, 35%, and their PaO2s were kind of right in that gray zone of not necessarily having to intubate or and give them surfactant, but they're working hard enough that it would be great to ease their respiratory distress. Need for intubation was greater than 40%. Or greater than 65 or less than 722, or severe apnea, hemodynamic instability, or deemed necessary. Treatment failure was decreased by 26%, and this was statistically significant. This was surprising to me. I really thought that the duration of CPAP and duration of oxygen requirement would be different. And thinking about it and talking to lots of people, what we've figured is that come to the conclusion that RDS is RDS. And so it's going to run its course over a couple days. But what the LMA or SALSA does for you is that it's able to get that baby through that with much less support in terms of the level or the FiO2 requirement. But the dichotomous on or off was no different. So again, 26% fewer intubation, and the procedure was well tolerated, required less time and fewer attempts. So when should you do it? This is different by every site. I'm of the belief that these criteria are different than if you're actually going to make your decision based on having to intubate or put a laryngoscope down. So at my facility, we actually use any FiO2 requirement as long as you have symptoms. And so if you're on 22 to 25% for at least a half hour, you are working hard, we're looking at your respiratory distress and your trend. And if you're trending up, we'll give you surfactant. If you're trending down, we won't. We'll just give you more time. Again, 25 to 40%. If it's stable or increasing, we give surfactant. But what I also found is that there is a time when you're too late. And so the babies that were increasing rapidly and rapidly traversing their FiO2 to 40 to higher and higher, those are the babies that likely are not going to be captured. And so it may waste a dose and waste time. And so those are the babies that I would consider just proceeding with a traditional method or a different method. But again, if they're stable or decreasing, we just hold and follow their trend. So what equipment is needed? The beauty of this is that it's highly, highly adaptable and versatile to what's at your institution. I teach a lot and roll this out a lot in some low and middle income countries. And so on the left is just an LMA and a syringe full of surfactant, and that's all you need. Versus you can also become much more complex in that the use of an adapter allows you to have continuous EEP during the entire procedure. Things like a CO2 detector are helpful. And again, there's multiple ways to have the surfactant administered, and you do not necessarily have to use a MAC catheter. The LMA, again, looks very similar to an ET tube. Most are familiar with it. And again, it sits just kind of in that posterior pharynx and does not need to have anything go through the vocal cords. Lots of different shapes and sizes. These are all for neonates. As you can see, they vary in terms of what the mask looks like, the shape, whether or not it's inflatable, and also the angle. CO2 detectors are very, very helpful. You don't need them, but it certainly decreases the time that it takes to readjust and do something differently. And capnography is something that's been really fun. I've started using that quite a bit just because you can sweet spot it. But again, it's completely not necessary, but kind of fun. Adapters, as I mentioned, make it so that when you give the surfactant, you don't have to actually uncap or just connect the PEEP. And so you can give continuous PEEP and not lose your FRC. Here's a picture with a Y piece. You can see that it's hooked up to an LMA. There's a PD cap that then is attached to your T piece or your bag. And then the other side is your surfactant administration port. And the beauty of a T adapter is that it takes all that extra equipment away, but they're actually a little bit hard to find and often on back order. But as you can see, then on your T piece, your PD cap and your ventilation is on the distal end, or proximal, I guess, to the LMA, and then the surfactant syringe just hooks right up into that port. We keep all our supplies in a little box that's labeled, so it's all ready to go. And as you can see in there, there's the algorithm. And then we also made an airway pole. And the reason for that is that our bedside monitors do not have capnography. And so we bought a pod just for this pole. And so that monitor does have capnography available, as well as the neopuff and oxygen and air, as well as a bubble CPAP. And so this is taken to the bedside for any LMA or intubations, and also goes to the delivery room. So who's doing it? Very hard to know. I've tried very hard to keep track. I've taught for lots and lots of years at many, many places that do not have a centralized registry yet, except for, I should say, now we do, because in the Near for Neos is a national airway registry for intubations out of Liz Foglia out of CHOP. And in October, we actually added a SALSA module. So this is wonderful if you're doing SALSA, but you do need to be part of the NEARS registry in order for that to be data collected. So if you're not, I encourage you to be part of the NEARS, the Near for Neos. There's a publication by Dr. Kubika that showed that it's being used in a level 3 nursery, 120 babies, and 70% success rate with CPAP. Internationally, I was very, very surprised to see that the European consensus guidelines recommended or said that it may be used for more mature babies. This was shocking to me because they are very, very pro-LISA in Europe. And this is wonderful for low and middle income countries. So you do not need to have a ventilator. You just have to be able to have CPAP and do it well as have the availability of surfactant. But a lot of my work now is in low and middle income countries in addition. So there's a Jordanian study that we're part of. Let's see if this works. This is a great video. That is not coming up. But they do it with just the LMA and the surfactant syringe. And the aliquots, they did 2 aliquots, and the start to finish was 19 seconds. Case report out of India. And then this is something that's near and dear to my heart. Taught for many years at the Tiny Feet, Big Steps conference in Tanzania and Arusha. And this past October was the 4th year. They had over 300 participants from 20 countries. And then the initiative that just started was through the Bill and Melinda Gates Foundation. The SASE trial is SALSA versus Insure. It's going to enroll 612 babies in Kenya, Ethiopia, and Nigeria. And I was just part of the training session in January in Ethiopia. So that will be starting here soon. So cool. I want to learn. We're just going to breeze through this, but there is an algorithm that can be tailored to your facility, your institution. Again, depends on what type of adapter you have, what type of LMA you want to use, cuff versus no cuff. I already looked at the video. And then just end up with the frequently asked questions. Do you need atropine? So I went back and forth on this in the study we did. It's in all of the low and middle income countries that we're gathering data from and have several studies. They are not using atropine, and many centers that I know of in the United States are not, and they are not seeing bradycardia. However, I have put it into my algorithm because I've decided that I want the algorithm to be as safe and as efficacious as possible. And so I did include atropine, but it is not necessary. Sucrose, same thing, yes, but not necessary. Lots of places are not doing anything in terms of pre-medication. Ativan, I actually love it in the older kids. And so while this is less invasive, it is still invasive, and that those older, like the 34, 35 weekers, are not pleased. And so they really fight you and they try hard to gum it out with their tongue. And so I find that a half dose or a dose of Ativan can be really helpful in that situation. Remove the OG. Again, this is variable. About 50% of the places are removing it and 50% are not. I did it for about 6 months where I did not remove it and it was fine. But I decided to have the algorithm say you should remove it. And that's for 2 reasons. One is that it may or may not interfere with the seal. And then secondly is when you pull out the LMA, I don't want it to kind of grab hold of the OG and pull it into the esophagus. And so for that reason, I've decided just in the algorithm to have it removed, but you do not need to do that. Dose of surfactant. Many have said, do you need more in case some leaks? We do not recommend a different change. In the study, it would have required an FDA approval to do a different dose. And what I've also found is that in my study, about 25% of the babies, I had about 10% or less in their stomach, and they had no problems with efficacy. And even the babies that had 50%, there was a few of those, and they still had a good efficacy. And so the dose of surfactant in the companies when I've talked to them is higher than what's actually needed for efficacy. So if you lose a little bit from leakage, you're often just fine in terms of efficacy. But again, there's been a time or two where I found 100% of the dose in the stomach and the baby did not respond. And so again, that would just need a redose. So leads me to redose immediately. Yes, if there was minimal response, that's only happened to me twice in about 20 years, but it can occur. And then later, again, as I mentioned, if the baby does respond and then slowly creeps back up, and you would normally give them another dose of surfactant, we do give it based on SALSA. So what resources are available? Here's the algorithm. It's online, free if you'd like it. And again, it's an Word document, so it can be changed to modified to your institution. There's procedure videos. I did a 14-minute training video. And this is old now that you do get this. On this training video, I give positive pressure the entire time, but you do not need to. There's a Neo Reviews if you like kind of a step-by-step in the kind of written form. There's a Bubble CPAP, which is a training institute that's all about Bubble CPAP. And then I have 2 modules there on how to give the surfactant by SALSA. There is a YouTube channel. There's a Facebook page. This has over 500 participants now and very, very international. So it's fun to see people's videos and where they're coming from. And so a conclusion, The answer is yes. You can have NIV and surfactant too. So with that whirlwind, I will stop and we'll take some questions.
Oh, you're getting, I don't know if you can see this, you're getting claps and thank yous. Already comment about thank you so much for giving a great presentation. This first question, I'm going to ask Pumi maybe to unmute and ask. I wanted to make sure that it was correctly conveyed. Pumi, are you on?
Yeah. Yeah, I'm on, Kara. Thank you so much for the great presentation. I have a quick question. I saw your video that you put the nasal CPAP while do administer the surfactant. So, do you think it's necessary to put nasal CPAP? Because of when I think LMA kind of occlude the vocal cord, right? I mean the trachea. So when we deliver the pressure nasal CPAP, it's gonna go mostly down to the stomach and it make more like distension. So my question is that should we give nasal CPAP while we are administering the surfactant?
Great question. So the beauty of the LMA is that it really takes up the whole posterior pharynx, and so there's not really room for it to even go down the esophagus. And so what we've decided is that you can leave the CPAP on or take it off. It doesn't matter because as you mentioned, the CPAP or the PEEP is going to come through the T piece solely. And so the reason to leave it on is because that mouth is open too, so it's escaping out the mouth or kind of around the LMA. And then it just avoids kind of that on and off, kind of, just the extra step. But also when you remove the LMA, that PEEP is right there and ready for the baby.
Thank you.
Yeah, thank you, Kari. One thing before the next question is, would you be able to stop sharing at that top port?
Yeah.
Yeah, so that they can see you and not see me.
Sounds good. I think you're seeing me and I was talking to myself.
Yeah. Now we got you. Can you see the gallery now?
Yes.
Okay,
Yep.
good. Yeah, I want people to be able to see you. So next question is idea or about the BPD rates and neurodevelopmental outcomes associated with LMA treated infants. We may have gotten a little bit of a taste for that with your big study after 10 years of doing this, but what are those outcomes?
Yeah. So BPD, again, surfactant is surfactant. So I'm not thinking that this is going to change. This is not going to be the holy grail in terms of changing BPD rates. But what this is going to do is allow the babies to get over their RDS on non-invasive. And so if you look at it from that standpoint, it should potentially decrease the BPD rate because we're not going to have the time on the vent. But that kind of remains to be seen.
Mm. And next, very good question. What do you do if the surfactant via the LMA was or maybe seems ineffective, even though nothing is aspirated from the stomach? For example, the baby was atelectatic, needs intubation. Do you redose the surfactant or do you wait for the 12 hours?
Mm-hmm. Yep, great question. Just depends on the baby. And so, like I said, and I've done lots and lots of these. There was a time when like everything just went incredibly, incredibly smoothly. The baby did not respond at all and 100% was in the stomach. And so that one we just redosed a full dose again and it worked just fine and it felt no different. And so it's going to happen once in a while. And so in that case, it was obvious that the baby did not respond and that we got a lot of surfactant out of the stomach. So clinically, go by that. If you get some out of the stomach and the baby responds, then we just, again, go by symptoms. And so, if the baby responds and then kind of slowly comes back up, then at the appropriate time, we would give it again if the baby's, qualified.
And along those lines, we have another nice question about previous studies on rapidly instilling surf, and that may result in a more even distribution of surf throughout the lungs compared to slow infusion,
Yes.
thereby promoting faster gas exchange and improvement, oxygenation, etc. So do you think that efficacy and effectiveness may be affected by slow administration through SALSA or LISA?
Right. So the, kind of the initial surfactant study did show that kind of a big and rapid bolus was best. And so that kind of begs in the speed and the size of the aliquot. And then now the new variable is whether or not you're having positive pressure or negative inspiratory pressure. So those studies were all done with positive pressure because we were bagging during those times, versus now for letting the baby spontaneously breathe, that's going to be done with negative inspiratory pressure. So whether or not that's different, there's not been any studies that I'm aware of that have looked at kind of the, radio tagged. I've done some of that work in preterm lambs as well as piglets, but I haven't had the opportunity yet to kind of sort through all those variables. And so it's something I would like to do and kind of do the bolus size, the speed of it, and positive versus negative pressure. In my heart of hearts, I'm kind of wondering if it's not going to make a whole lot of clinical difference. Surfactant works great for the most part if you get into the lungs. And I think the kind of the stuff that we're seeing from the negative negative pressure installation is showing that the kind of the gravity in the lungs do help kind of it move through in a more uniform distribution.
So we have, Oh, nice question. This is what's the smallest gestational age or weight baby you have surfed via SALSA?
Yeah, the smallest that I've done is a 960 gram. And so that was with the AirQ. The AirVia has just recently been FDA approved, and that's for less than a kilo. So when those are clinically available, I will be trying those out in the smaller ones. The ones that were clinically available in the past, they are mostly used in kind of like the less than 2 kilos, but kind of the lower limit was about 1,250 grams, which is where I was comfortable with in terms of size. But there was case reports of 800 grams, and a lot of the people that I've been talking with in Europe and the UK had used them even down to 800. So that tells me that there's kind of quite a bit of flexibility. So the ones that were, I was kind of stopping at 1,200. Others were safely putting them in an 800 gram baby. So ones that are even smaller make me comfortable that we should be able to work our way down here in kind of a stepwise, careful manner. But we should be marching down here and have the ability to give surfactant to smaller kids.
And with the down to 800 or 900 grams or so, is that with the AirQ point or AirQ size zeros, or was that a different?
That was with the iGel. So even the ones that were kind of being used in the bigger babies, they had been used even down to 800.
Fantastic. We have a question about, is there anyone or you who have looked at the percentage of the babies who've received 1 versus 2 doses of SALSA? Is there a feeling that maybe there's more doses with SALSA versus not, or other ways of administering?
Versus Ensure or versus?
Maybe in general is what it sounds
In general?
like.
Yeah. I think, again, it depends on what your threshold criteria is. At my institution, we are very, very liberal with our surfactant. So we're a center that in the past, we were trying to rein this in a little bit, but in the past, if you were in need of a second dose, you got a second dose, even if you were just a little bit grungy. And so we're trying to rein that in versus a lot of places that I've been in that are much more conservative on their use of surfactant, are letting the babies get to 40 or 50% and grunting. So again, I think it's kind of one of those is what you're tolerant of, or kind of where your comfort zone is. So again, kind of a wishy-washy way of saying there's nothing that needs to be protocolized about this. It can be very adaptive to what your institution feels is appropriate for when to give a surfactant dose.
It seems very difficult to follow with all the kind of cultural and ways and biases per institution.